Good evening. It gives me a feeling of great pride to welcome you all for Journal Journey. This monthly academic activity has entered its third year, and it goes without saying that the committee carries expectation from pediatricians all over Maharashtra. We choose topics which are helpful for general pediatrics who work in periphery. And friends, believe me, we, the generalists, are the one who have to be extremely knowledgeable and up to date, because we have to handle the emergencies, we have to pick up a developmental delay, or to face a type 1 diabetes who may not show that he is having any symptoms. We give first aid and stabilize the patient and then refer to super specialty. So a big salute for all of you. And those who have chosen to work as general pediatrics in periphery. Now I hand over mic to our extremely talented editor of Raigad IAP and EB member, Dr. Neha Singh.
Thank you, Chitra ma'am. Good evening, everyone. On behalf of Maharashtra IAP and Raigad IAP, I, Dr. Neha Singh, welcome all the respected dignitaries and colleagues for today's journal journey. I welcome Maharashtra IAP President, Dr. Ram Gopal Chejara sir, Secretary General, Dr. Amol Pawar sir, as well as all the respected executive board members of Central IAP and Maha IAP. I also welcome Raigad IAP President, Dr. Vikas More sir, Secretary, Dr. Ajay Kohli, Dr. Hemant Gangolia, our patron, Dr. Niman Mohanty sir, Dr. Jay Bhandarkar sir, Dr. Chitra Kulkarni, and all the members from Raigad IAP, Navi Mumbai, and other branches. Today's session has been granted 1 MMC point, so requesting everyone to type their name, MMC number, Central IAP, and city in the chat box. For today's session, we have two experts, Professor Dr. Subramanya NK sir. Sir is Medical Superintendent and Professor of Pediatrics at Kuppam, Andhra Pradesh. Sir was Central IAP VP South Zone 2022. And our second expert is Dr. Swarup Kumar Das, Senior Neonatologist at Latifa Women and Children Hospital, Dubai. Our two presenters for today are Dr. Mitali, Senior Resident at VMG Medical College, Sholapur, and she will be presenting on non-breast milk fed very preterm infants at increased risk of iron deficiency at 4 to 6 months corrected age. And this is a retrospective population-based cohort study. And our second presenter is Dr. Vikram Patra sir. He is consultant pediatric allergist practicing at Navi Mumbai. He will be presenting What's New, the Gina Guidelines 2023. So now I request Dr. Mitali to please share her slides and start with the presentation.
Okay. Good evening, everyone. Thank you. At the outset, I'd like to thank Dr. Chitra ma'am, Dr. Niman Mohinte sir, and Dr. Neha Singh ma'am for giving me this opportunity to present on such an esteemed platform. Without further ado, let's begin our journey today with the topic. Non-breast milk fed very preterm infants are at an increased risk of iron deficiency at 4 to 6 months corrected age, a retrospective cohort study. The authors are as below, and the study was conducted at IWK Health Center, Canada. It was a recently published study on 30th of January 2024 and in the Journal of MDPI. So we all know that understanding the iron status in very low birth weight preterms is crucial for developing effective interventions. Both preterm birth and low birth weight are independent risk factors for iron deficiency, and iron being such a critical nutrient, if left uncorrected in early life, can lead to hazardous impact on the developing brain, which could be irreversible. It can lead to poor growth, poor cognition, poor immunity, reduced exercise capacity, pica, breath holding spells, febrile seizures, just to name a few. There has been prior research correlating low birth weight and iron deficiency, but there are very few studies comparing the levels of iron in the very low birth weight as per their feeding history. So the objective of this study was to explore the relationship between the feeding pattern and iron deficiency in very preterm infants. And the secondary objective was to explore the risk factors associated with iron deficiency in exclusively formula-fed preterm babies. So now there's a common assumption that breast milk contains low iron, so iron supplementation is commonly recommended in breast-fed babies. And the formula is deemed to be at lower risk because formula is already rich in iron. But when this study compared the two infants at 4 to 6 months of age, the left-hand side infant, which was exclusively breastfed, was having a better iron status compared to the right ones, which was formula fed. So this recent work by the group demonstrated that formula feeding was an independent risk factor for iron deficiency. And in comparison with the breast milk fed babies, they had higher odds of developing iron deficiency. But it was not clear whether this association was due to the decreased iron intake in the formula group or due to decreased bioavailability of iron from the formula. So what do we have in current recommendations? The CPS recommends, that is the Canadian Pediatric Society recommends no additional iron for preterm infants less than 2 kg if they are primarily fed with iron-rich formula, but it should contain at least more than 10 milligram per liter of the formula. AAP and ESPAGAN have given similar guidelines stating that the iron requirements of preterms range from 2 to 4 milligram per kg per day. But none have specified based on the weeks of gestation what is the iron requirement or whether the feeding pattern can affect the iron requirement of the child. This was a retrospective cohort study at IWK Center. They used an Allen perinatal follow-up program database. Now, this database captured all the data of the preterms ranging from perinatal age group to their NICU stay, the requirement of transfusion, their feeding type, feeding history, and they were followed up to 6 months of till infancy, and their serum ferritin levels and hemoglobin levels were measured. And all of this data, although the study was retrospective, the data was collected in a prospective fashion, which makes the study interesting and is one of the strength of the study. The study included all the very preterms in Nova Scotia ranging from a 13-year period of 2005 to 18. They excluded criteria like infants with congenital malformations, chromosomal abnormalities, hemolytic anemia, those fed with cow milk, those fed with non-iron rich formula. And all the eligible ones were then given iron supplements starting at 2 to 4 weeks chronological age as per the guidelines for preterm infants. Their hemoglobin and serum ferritin levels were also measured during their NICU stay every 3 to 4 weeks, as well as at 6 months follow-up check in the PFUP database. Babies were advised continuing iron prophylaxis up to 1 year of age. Each infant was followed up through the database and for growth, for developmental check, wherein their feeding history, the formula brand they used, the average daily formula volume intake, as well as lab parameters of the babies was measured, taking their hemoglobin, mainly hemoglobin and serum ferritin. So to identify which formula gives what content of iron, a market survey of all the formula brands was done in the area, and total daily iron intake of each infant was calculated based on the iron content coming from the branded formula that they used, plus the iron coming from the brand of supplement of iron they are taking. And then iron deficiency was defined as serum ferritin less than 20 microgram per liter at 4 months corrected age and less than 12 microgram at 6 months corrected age. To avoid biases and confounding factors, other variables that can affect the iron status, like maternal factors like anemia, PIH, smoking, GDM, antepartum hemorrhage, multiple births were considered. Also, neonatal factors like gestation age at birth, birth weight, length of hospital stay, need for blood transfusion in the hospital, IVH, NEC, PDA, etc. were considered. And based on the feeding type, they were classified into two groups, breast milk fed and exclusively formula fed. So the two groups were compared using unpaired t-test and chi-square test. And p-value was obtained for serum ferritin using Wilcoxon-Mann-Whitney test. P-value of less than 0.05 was considered significant. And to identify whether the feeding type itself is an independent predictor of iron deficiency, a multivariate regression analysis was performed to adjust for the maternal and fetal disturbances. Analysis was completed using SPSS statistics version 27. And here were the results. A total of 917 very preterms ranging from 23 weeks to 30 weeks gestation age were taken into account and were studied for this duration of 2005 to 2018. After excluding the major exclusion criteria, again, it included a large number of those which they couldn't collect the blood sample. That is a large number here. 570 met the inclusion criteria. Out of the 570, again, a large number had to be excluded due to unavailable lab data, 156 of them. And then ultimately only 392 were included, roughly 35 to 40% of the initial number. And out of them, they were further classified into two groups, exclusively formula fed with iron-rich formula, a higher number, 285 out of the 392, and the rest was breastfed. So the charts that were included in the study, the post-discharge characteristics of formula-fed versus breastfed milk babies at 4 months, if you see, the formula-fed had higher iron intake coming from supplements as well as formula, while the breastfed has lower iron intake. But the iron deficiency was found to be very high compared to the breast milk group and the formula-fed group. If you compare the iron indices of the two groups, serum ferritin levels were relatively very low in the formula-fed group compared to breast milk group. This chart just depicts that all the parameters variables, maternal and fetal variables were, and as well as baby variables were taken into consideration. And if the exclusively formula-fed were further divided into iron deficient and non-iron deficient groups, the babies which were iron deficient were high on the post-discharge preterm formula intake compared to the non-iron deficient group. Iron obtained from the formula was high in the iron deficient group. So why these contrasting results? Average intake from formula and supplements is 2.6 milligram per kg per day. And for the breast milk group, it was 2 milligram per kg per day. But the prevalence of iron deficiency in the formula was 36.8% compared to 20.6% in the breast milk fed group. And when calculated the iron intake from formula alone without supplements, only 20% infants had more than 2 milligram per kg per day of iron, which meant that 80% of them, which were formulas, couldn't supply even 2 milligram per kg per day. So do formulas alone provide enough iron for preterms? It raises the question. To explain these contrasting results, three hypotheses were provided. The first being that iron in the breast milk is bound to high molecular weight molecules and the iron in formula milk is bound to low molecular weight molecules. So a study conducting by mass spectroscopy found that these low molecular weight molecules in the formula decrease the bioavailability of the iron. And one of the reasons for this, which could be one of the reasons for this discrepancy in the results. Second hypothesis is that lactoferrin, we all know, is in high concentrations in breast milk, and this contributes to the increased iron absorption. And the third, that the hepcidin hormone. Now, hepcidin sequesters the iron in the hepatocytes. So, low iron is therefore available for erythropoiesis. And the study conducting the hepcidin hormone in the breast milk fed group found that they have relatively low hepcidin levels compared to the formula milk group. The second objective was to identify independent risk factors for iron deficiency in the formula fed group. And they found two major risk factors. First was gestational hypertension. Normal pregnancy serum and cord hepcidin levels are relatively low. But in gestational hypertension, the hepcidin levels tend to rise. And this may reduce the transfer of iron from the mother to the fetus. Second, is birth weight less than 1,000 gram as an independent risk factor. Or as usually the preterms and low birth weights are delivered in the late second trimester or early third trimester, and iron transfer usually happens in the third trimester. They are already lacking in the iron stores. They have a variable neonatal course and they are in need for blood transfusion. So it could be one of the, that's why it is a risk factor for iron deficiency. And third was not an independent risk factor, but was an observation, interesting observation that was found that all the blood transfused neonates were likely to be iron deficient. That is mainly because the pediatricians usually tend to restrict the adding immediate iron supplements to the preterm babies who are blood transfused in the fear that they might overload the baby with iron. But we need to instead use microsampling techniques to reduce our phlebotomy losses. We need to delay cord clamping, and we need to adhere strictly to the restrictive transfusion guidelines so as to avoid and use a risk adapted strategy when considering whether iron is to be given or not to the babies. The strengths and limitations of the study. Strengths is that it's a population-based study design. It has a large sample size and it was prospectively captured clinical information. Limitations, unavailable lab data for a lot of babies, like 156 to name. And also lack of data on other markers of iron deficiency like transferrin saturation, TIBC. Ferritin was used as a marker for iron deficiency, but it is an acute phase reactant and it might hamper the results, leading to false positive rate. And it was a retrospective study design. Iron for solid foods was not included, could be a limitation, but we can turn a blind eye towards it, as usually at 4 to 6 months we start solid food. So the amount of solid foods that is introduced is meager at that age. So iron coming from that is also probably less. To conclude, non-breast milk fed very preterms have high prevalence of iron deficiency despite the higher iron intake than their breast milk counterparts, milk fed counterparts. And this underlies the need to monitor the iron status in these and babies and to recommend additional iron supplementation. To use a risk adapted strategy when to decide on iron supplementation could be helpful. And obviously, these observations suggest that we need to revisit the international recommendations for iron supplementation. Further research on the bioavailability of iron coming from formulas versus breast milk is needed to corroborate these findings. And addition of more bioavailable iron species to the formulas should be considered over increasing the content of the iron in the formula in order to prevent iron deficiency in the formula fed very preterm infants. Thank you.
That's a very good presentation, Dr. Mitali. You were very clear, methodic, to the point. Now, Dr. Saurabh is held up. He has conveyed just now that he is unable to connect from Dubai. So in his place, if you permit, I will just some comments I will make, because it was his helplessness. He's feeling regrets what to do. Now, what do you think? What message it gives to us in our pediatrician practice in the rural Maharashtra or in India? This study, what message it gives us? Mitali?
If a similar study was to be conducted in India, we can actually try using this, like in our NICUs, we should use this database, a follow-up program wherein we collect data of all the delivered babies, all the NICU admitted babies, and just during their follow-up, whenever they come for vaccination and all, we should collect more data so that we can publish more and more. And considering the sample size, we do have lot of uh, babies as compared to the Western population. So
Yeah.
it would be better if we have such a database so that we can have more accountability for what we study. Other thing, a similar market survey can be done for our formula brands that are available in India to know the exact iron content. And also the issue of accessibility, affordability of the formula, and should be taken into account as one of the variable when we consider India or other developing countries.
That's right. About the confounding factors, although they have not mentioned anywhere, how many babies also received delayed cord clamping, or how many babies received erythropoietin, they have not mentioned. These are the very important confounding factors could influence the study.
Yes, that was in difference.
And this is a retrospective study. The strength of normally the retrospective studies, their strength is weaker than the prospective studies. As Mitali suggested, since we have got ample number of cases, we should do some prospective studies. Maybe from different centers we can do it. Multi-centric study is a very good suggestion Dr. Mitali gives us. We can collaborate with all over the country, and from multiple sites we can conduct these studies. The Raigad IAP may help. Thank you. Now about the very short comment from my side, I can only say that we already know that anemia is very common in extreme low birth weight. 90% of them receive at least one blood transfusion during their NICU stay. So this kind of a situation is there. The causes are very many, and we know the iatrogenic bloodletting is a very important factor, apart from the isoimmune hemolysis, genetic red cell destruction, and physiological causes are also there. So in the hemoglobin levels of neonates to consider, in term babies, normally the term baby attains hemoglobin level of 13 to 14 grams by 4 weeks and 9.5 to 11 grams by 7 to 9 weeks. This is we designate as a physiological anemia. And in the contrast to this, in the preterm, it is 6.5 to 9 gram by 4 to 8 weeks of life. So that is the difference between the normal and term and preterm babies. Most of the term babies and the preterm babies have adequate iron, folic acid, and B12 level at birth. This is a very interesting. We presume that the iron store is depleted in the preterm, although in our country things may be different. This is the Western data, what I am talking. In our country, the mothers are themselves so iron deficiency anemia, so they may be having reserve low iron reserve. But the studies show that at birth, preterm as well term babies have normal iron store, and as well as B12 and folic acid levels. B12 and folic acid level decrease in preterms by 2 to 4 months of age. Whereas it remains normal in term babies. That's why the preterm babies suffer the brunt to a great extent. Then enteral iron supplementation in preterm is recommended. Low birth weight babies in supplementation lead to increase in hemoglobin concentration only to a modest extent, but is 0.6 grams per deciliter. Although iron stores improve, the subsequent iron deficiency anemia risk decreases. Now, the treatment of this is the limiting the iatrogenic bloodletting, but Dr. Mittal has very well commented. Iron supplementation for all preterms at the rate of 3 milligram per kg from 4 to 6 weeks of life. As full feed is established, or iron fortified formula with 0.5 to 0.9 milligram per deciliter, they say. This is the recommendation. But she said this is 90, it's all right, 90 per liter, she said. And folic acid supplementation, 50 microgram daily or 500 microgram per week. Erythropoietin from 2 to 4 weeks, 100 international units per kg subcutaneously, 3 weekly to be given. And iron therapy may be increased to the extent of 9 milligram per kg, they say, during the EPO therapy. Then the other important thing is, if we do this delayed cord clamping, this anemia problem, we will win this battle, because we have conducted a study in MGM, about 500 babies you have seen. These babies, in preterm babies also, they did not suffer from the dip in the physiological, so-called physiological anemia. Apart from the additional about 50 to 60 ml of blood they get from the placenta, that may be something, some stem cells which is doing this tricks. The hemoglobin level is adequate. They are we have done that development milestones also for 1 year of age. This is almost different from the babies who did not receive the milking of the cord blood. So this is very, very useful, and this may help in our program for preventing iron deficiency. Regarding the present study, it is a retrospective cohort study, as she has already elaborated. It was found significantly more prevalent among the non-breastfed, very premature infants, which is not unexpected at 4 to 6 months corrected age, despite a higher iron intake than the breast milk infants. Obviously, is because of the lactoferrin present in the breast milk. Bioavailability of iron is more in breast milk, so that is very important. And nowadays, if you see, again, we have to think and take the fact seriously that these industries are very aggressively marketing their stuff, and in corporate setup, most of our babies get the tinned milk, but in the bottles at the first feed, claiming that the first feed baby cannot suck, it is weak, and it goes the prescription goes from the nurses or the dyes directly to the outside, and once the baby sucks from the bottle with a easy sucking, the babies will be reluctant to suck from the breast. It is little effortsome. So that's why we must again think about this and how we will involve our obstetrician colleagues to help us in this regard. Preterm infants are at increased risk for developing iron deficiency anemia, as she has said it, and is recommended to provide them with the prophylactic iron supplementation earlier than what is being done in the society today, in the community today. However, large-scale prospective studies, I suggested we may think of this. Thank you.
Thank you,
Dr.
sir.
Mitali, you have presented a very nice article, and I would like to appreciate for the presentation made by you. It was very creative and attractive. So our second presenter is Dr. Vikram Patra, sir. And sir, kindly share your presentation. He will be speaking on what's new, the Gina guideline 2023. Over to you, sir.
Thank you, Dr. Neha. At the outset, let me thank Dr. Nima Mohanty sir, Chitra Kulkarni ma'am, Jai Bhandarkar sir for inviting me for this talk. And thank you IIP Raigarh and Maha IIP. So today we will be discussing about what is given
Sir,
in the
audio.
Sir, your audio is very low.
Sir, can you increase the volume?
Come little nearer to the mic.
Is it audible now?
Yeah, better.
Better.
Yeah. So today we will be discussing what's new in the latest Gina 2023 guidelines. And when it comes to Gina, for many of us, it is very confusing and very volatile. And Gina don't make us sit idle. Every year they come out with something new. We have new thing, and whether it is confusing or not, we'll discuss. So actually, what's the reason for coming out with every year they come out with new guidelines? Because this is based on the research work, and based on then some of the other difference in the treatment line or in the management of asthma line, it comes. So before understanding the Gina 2023, what's new, I'll go briefly about the what is Gina 2023. And as previous Gina guidelines, this year also they have divided the treatment algorithms into 3 parts: less than 5 years, 6 to 11 years, and 12 adolescents and adults. So most of the differences are in the adolescent adults and 6 to 11 years. Very few changes in the below 5 years. So let us go one by one. The most important thing where they have highlighted is the personalized control-based asthma management. So in each chart, in each age group, they have represented this chart. This is called as the assessment, adjustment, and review. This circle is going to be there in each chart. We'll see what are these charts actually. So first is assess. And what is assessment? Whenever a patient comes, we have to come out with the confirmation of the diagnosis. If it is necessary, it's a new case. If it is already an established case, then we have to assess for the control, symptom control, and modifiable risk factors. We have to assess for the comorbidities, inhaler technique, and adherence. So at every visit, we have to assess all these points. And what all questions we need to ask about the asthma symptom control. So only 4 questions we need to ask to determine whether the asthma symptoms are under control or no. So 4 questions in the last 4 weeks: whether the child had daytime asthma symptoms which were more than twice a week, whether there was requirement of SABA reliever for symptoms more than twice a week, whether there any night waking due to the asthma, and 4th point is any activity limitation due to asthma. So if you get all these 4 or at least 3, then you will label the child to have uncontrolled asthma 3 to 4. Partly controlled is if you are getting yes to either 1 or 2 questions, and if none of this is there, that means the child is having a good control. So, and what about the modifiable risk factors? Once if the symptoms are not controlled, we have to look for these modifiable risk factors also. Then comes the adjustment. So once we know the assessment of control, then we adjust or we change our treatment line. And first of all, allergen exposure, irritant exposure, we have to avoid. Physical activities, then avoidance of occupational and domestic exposures to the allergens or irritants. Then avoidance of medications that may make asthma worse. Avoidance of indoor allergens, breathing exercises we have to promote, and weight reduction is one of the thing which we must highlight for all the patients. And then we have to review about the exacerbations, whether there are any risk or no, side effects, and the lung functions. Now there are various new terminologies which have come into the picture. Now previously we were knowing the asthma medications were divided into 2, reliever and controller. Now exactly controller means ICS containing devices. But now the word which is preferred is maintenance treatment. Now in maintenance treatment, it can be ICS containing device or Montelukast or biologicals. So maintenance treatment means what? If we are writing something and we are asking the patient to take for a prolonged period, for a desired, say 3 months, 6 months, whatever. And reliever, anything which is taken when the child or the patient is having asthma symptoms or during acute attacks. Those are called as reliever. 2 new terms: anti-inflammatory reliever. Reliever inhaler that contains both a low dose ICS and a rapid acting bronchodilator. They are termed as anti-inflammatory reliever. And then maintenance and reliever therapy means, that is previously used to be called SMART, now it is called as MART, M-A-R-T. So treatment regime in which the patient uses an ICS and LABA particularly formoterol as maintenance dose, and also uses the same medication as needed for relief of asthma symptoms. So that means there will be a single device which will be used as maintenance as well as reliever therapy. Now, anti-inflammatory reliever therapy examples are again ICS formoterol or ICS SABA, and this provides rapid symptom relief plus a small dose of ICS, reduces the risk of exhaustion compared with using a SABA reliever, and regimes with ICS formoterol anti-inflammatory reliever, those have as needed only ICS formoterol air only. The patient takes low dose ICS formoterol whenever needed for symptom relief, not a continuous basis. Only whenever it is required, the patient takes. We'll discuss all these regimes in our future slides. Then maintenance and reliever therapy with ICS formoterol. A low dose of ICS formoterol is used as patient's maintenance as well as and when needed. Now, AR that contains both low dose ICS and rapid acting bronchodilator includes budesonide formoterol, beclomethasone formoterol, and ICS salbutamol. No other LABA is used, only formoterol is used. Patient can also use them as needed before exercise or allergen exposure. MART, as I mentioned, it is for maintenance as well as reliever. Now, few definitions has been changed. Now, there are epidemiological definitions as well as clinical definition. Mild asthma is currently defined as asthma that is well controlled with as needed low dose ICS or low dose ICS plus as needed SABA. So no regular medication is required. Only whenever required, the patient takes. So that is that time we call it as mild asthma. Moderate asthma is currently defined as asthma that is well controlled with step 3 or step 4 treatment with low or medium dose ICS LABA. And severe asthma is defined as asthma that remains uncontrolled despite optimized treatment with high dose ICS LABA or that requires. Now, at the beginning, previously, long back, previously at the onset, only we used to label. Now, these definitions are retrospective. Once the patient, we see the response after 4 weeks of giving ICS and LABA. Now, coming to the various age group algorithms, first we'll discuss about the 6 to 11 years. Now, this is the Gina 2023, where we are going to start treatment. Now, where similarly, as previous guidelines, step 1, step 2, step 3, step 4, step 5 are there. Now, when to start step 1, whenever the symptoms are less than twice a month, then the preferred controller is low dose ICS taken whenever SABA are taken. Previously, we used to write only SOS SABA previous guidelines. Now, wherever you are going to use SABA, we must use a low dose ICS also. So SOS basis only for a period of say 7 to 14 days, we need to give. And then again, when it is required, because the symptom frequency is very less, twice a month. Now, what if symptoms twice a month or more, but less than daily? Now the symptom frequency is more, then you need to go for a maintenance thing with the low dose inhaler corticosteroids. Then the third step is when you get night awakening symptoms. So in addition to daytime symptoms, when you start getting nighttime symptoms once or more in a week, then you have to step up the treatment. And in addition to low dose ICS, you have options. You can either increase the dose of ICS to medium dose ICS, or low dose ICS, you can add LABA, or very low dose ICS formoterol. And step 4 is medium dose, further you are increasing. And step 5 is uncontrolled asthma, where you are going to add anti-IG and mepolizumab, all these things. Now here you can see a reliever. So as needed SABA along with ICS, or if the child is already on ICS LABA formoterol, then in step 3 and 4, the reliever medication will be the same ICS formoterol. So instead of giving 2 MDIs, salbutamol and budesonide, we need to give only one, avoiding confusions. So in first only we discussed that no SABA alone treatment. So why this thing came into picture? Because patients of mild asthma also. Now those are considered to be mild, because as I mentioned, the definition of mild asthma is step 1 and 2. So mild asthma, patients of mild asthma are also at risk of serious adverse events. So now SABA alone, if we keep giving, what happens? The inflammation continues, and there will be an increased risk of exertion and reduction in lung function in future. So further, increased use of SABA has been observed with beta receptor down regulation. Thus, there will be decreased bronchodilator response in future. There will be rebound hyperresponsiveness as inflammation is going on, increased allergenic response, and higher uses of SABA has been associated with increased morbidity and mortality also. So there was a pilot study trial where ICS reduced risk of serious exertion was seen to be 50% even in mild asthma. Now the second step already mentioned. So the doses where what we recommend is, when I was talking about low dose and medium dose, so the commonly used ICS what we use is budesonide. So for adolescent and adults, the low dose is 200 to 400, medium is more than 400 to 800, and the high dose is more than 800. Whereas for 6 to 11, this is half. The low dose is 100 to 200, medium dose is 200 to 400, and high dose is 400. So no need to remember every other ICS because we are commonly using budesonide only. Now the step 3, it comes low dose ICS and LABA. Now this is what we call it as MART. Now here MART means maintenance and reliever therapy using ICS formoterol, both for maintenance and treatment. And remember, MART is only available for ICS and LABA combination, in which the LABA has a fast acting component, formoterol, that is formoterol. Now we know we have heard about salmeterol, we have heard about formoterol. So whereas formoterol is rapid acting, that's why we can use as reliever, whereas we cannot use salmeterol as a MART therapy. Now what is a long acting but also fast acting. The onset of action is within 1 to 3 minutes, and the duration of action is also up to 12 hours. So now we two types of combinations we use: budesonide formoterol and beclomethasone formoterol. In pediatric age group till 18 years of age, budesonide formoterol is preferred. Now, reliever doses of ICS formoterol, how much can be taken? Now, the question arises when it is mentioned that now previously we used to use ICS LABA combination, and in addition, as and when needed, SABA we used to use, and that we could use around 2 hourly, 3 hourly also. Now, the question here is how many times we can take ICS formoterol in a day. So maximum doses, suppose the patient was taking 1 puff of budesonide formoterol, they can take around 12 inhalations. Adult patients can take 12 inhalations, whereas children can take 8 inhalations. So that means the total dose of each puff, the dose is 6 microgram of the formoterol. So the maximum dose for formoterol in a 24 hours is 72 microgram for adults and 48 microgram for children. Now, and when you are prescribing all these things, parents also may be worried, itna sara puff, how can they use? So what we need to emphasize is hardly any patient will require this many doses. So this is the maximum dose what you are saying. So next is the 4th step, where there was no response, so we have increased further to the medium dose ICS LABA. And then if it is not under control, then specialist opinion will be required, and where phenotypic assessment and addition of biologicals will be warranted. Now, when I was talking about biologicals, the newly introduced in this Gina 2020 is the mepolizumab. Previously, omalizumab was also there. Mepolizumab is an anti-interleukin 5 antibody, which is added to step 5, where patient with severe eosinophilic asthma is encountered. And regardless of regulatory approvals, Gina recommends biologic therapy for asthma only if asthma is severe and only if existing treatment has been optimized. So we have reached to the maximum dose of ICS with the proper technique, proper adherence, everything, then only biological we should opt for, otherwise we should avoid. And coming to the doses for the MART or the combination, step 1 and 2, it is called as AIR. AIR means there is no maintenance, as and when needed, but we have to use anti-inflammatory and reliever, that is budesonide formoterol. So age group below 12 years, that is 5 years to 6 years to 11 years. There we are using in step 1, step 2, we are using only budesonide. But in adults, in step 1 and step 2, we'll discuss further. Budesonide formoterol, 1 inhalation can be needed as and when needed. And MART therapy, the doses you can see, we need not discuss in details. How it is prescribed for step 3, 1 inhalation once daily, as it is low dose. In step 4, it is one inhalation twice daily. And for step 5, it is 2 inhalation twice daily. So this is for children age group 6 to 11, I have mentioned. Now coming to adolescents and adults, now there are 2 tracks, which was not there in previous guidelines. In this guideline, they have made it 2 tracks, depending on the choice of reliever. So in this guideline, the patient's choice has been paid attention, the attention has been paid to the patient interest. We have to optimize the inhaler selection also, safest and best for the patient and for the planet. So the chart, the algorithm, we can see track 1 and track 2. So, but the preferred one is the track 1 itself. Track 2 is again, depending on the personal choice of the patient, we can go ahead. Otherwise, track 1 is preferred. In the track 1, step 1 and step 2, they have been combined and only air treatment is required. As I mentioned, low dose ICS formoterol as and when needed. And when it is required, whenever the symptoms are less than 4 to 5 days a week, you just give as and when needed, no need for continuous therapy. In step 3, if the symptoms most of the days and nocturnal symptoms have started. So in such conditions, we have to give daily doses, that is low dose maintenance ICS formoterol. And when these symptoms are associated with low lung function, ideally we should go for low lung function in each and every patient. But if we get it, then we'll start with the step 4, directly medium dose maintenance ICS formoterol. And step 5 is same. If after optimizing there is no response, then we have to go for biologicals. So as I mentioned, air is only for step 1 and step 2, and MART therapy step 3, step 4, step 5, and reliever is always air, anti-inflammatory reliever, where ICS and formoterol. Track 2, just for discussion, otherwise we should not prefer. Step 1 is take ICS whenever SABA. Now here the patient is not taking combination of formoterol and budesonide, right? The patient already had budesonide inhaler with him and the salbutamol inhaler with them. So in such condition, if the patient was taking only SABA whenever required, we have to ask them to take even the pink puff also, that is the budesonide. And step 2, low dose maintenance ICS, and step 3 is low dose maintenance ICS plus LABA. Here LABA they have not mentioned about the formoterol. Other LABAs can be used, but whenever there is reliever required, we have to add on SABA or the ICS and SABA. Now this is the algorithm for the adolescent and adults. Now, despite the addition of ICS SABA reliever, this is for the first time ICS SABA are also discussed. Reliever in track 2. Track 1 with as needed ICS formoterol remains the preferred treatment approach for adults and adolescents. Now, remember, ICS formoterol containing MDS only should be used. ICS can be anything, can be budesonide, can be beclomethasone, or can be fluticasone also. Less than 5 years, only one change. In the step 1, there is insufficient evidence for daily controller. And when it is, now this is the case, these are the cases where we get frequently. Now, infrequent viral wheezing, and there is no or few interval symptoms. In between, there is no symptom. So it is not, the symptoms are not consistent with asthma, but wheezing are there, and the frequency is less than 3 per year. So in such conditions, there are poor evidence to start daily controller. And some alternate way, what we can do is a short course of ICS for say approximately 7 to 10 days at the onset of viral illness has resulted in early recovery. Whereas in step 2, if the symptom pattern not consistent with asthma, but wheezing episodes requiring SABA occur frequently. So if there is history of frequent nebulizations and physician documented wheezing more than 3 in a year, then we should go for a trial of low dose ICS for a period of 6 weeks. If there is response, we have to continue for a period of 3 months. Now here we need to understand the symptom pattern, or we have symptom pattern consistent with asthma, and asthma symptoms not well controlled or more than 3 exacerbation per year when you are giving SOS ICS. Now step 3 is for asthma diagnosis is confirmed and asthma not well controlled on low dose ICS. So here what you have to give, you have to double the dose of budesonide. So if the patient was taking 1 puff twice a day, you make it 2 puff twice a day. So And before stepping off, always check for the alternative diagnosis, because younger the age, the more are the differentials for wheezing. Check inhaler skills, review adherence and exposures, and then only you step up. In step of 4, continue control and refer for special assessment. Means even after doubling the dose of ICS, low dose ICS, the patient is not responding. Then you have option of increasing the ICS frequency or adding on a leukotriene receptor antagonist. So if time permits, we can go to 2 cases. Case 1, 7-year-old Rahul, history of frequent cough, nighttime awakening almost 3 times a week, early morning breathlessness many times a month, misses school once or twice in a week, several visits to a practitioner and salbutamol nebulization several times, purchased a nebulizer at home. Now, this is a naive patient where the child was not on any MDI. So first of all, what is the level of control? It's a poorly controlled, because out of those 4 questions, we can see all the questions are ticked yes. So at what step you position him? So here he is lying. The symptoms are most of the days as well as nocturnal symptoms are there. So in such patients, as the child is between 6 to 11 years, low dose ICS plus LABA combination we need to start. The second case is an adolescent girl, Vidhu, weighing 59, height of 145 centimeter, history of hospitalization for wheezing about 3 to 4 times a month, and also history of frequent midnight visits to the casualty. So after an acute exacerbation, she was started on low dose ICS and SABA, and she is taking the same for last 4 weeks, but she is still coughing almost daily and wakes up at night coughing 2 to 3 times a week. So she frequently misses school and not participating in sports. So first of all, assessment of the control. Now we can see daytime symptoms are more than 2 times a week. There is limitation of activity in the case, and there is requirement of reliever therapy. So she is labeled as uncontrolled, and we need to step up, and we will step up with the medium dose ICS and formoterol. Thank you.
Thank you, Dr. Vikram. It was very nicely explained. And now we want to hear comments from Dr. Subramaniam, sir.
Thank you, Dr. Chitra and Mahayapi. First of all, let me congratulate both the speakers. Even the first one was also very nice. And being very, very selfish, let me also thank Dr. Vikram for making that lucid presentation of Gina. He was referring to is Gina confusing in the first slide. Whether it's confusing or not, Gina yaha, marna yaha. You don't have a choice. So we have to go by Gina only, and we have hardly got any choice. Now, there are 2 terms that have been newly used in Gina for all of you. One is AIR, that is anti-inflammatory reliever. So we were just thinking that relievers are not anti-inflammatory in the beginning. What I meant was that either we were offering salbutamol, salmeterol, or formoterol, but we were not considering anti-inflammatory drugs with reliever. So we are not having R alone. We are always having AIR. That's the major change that everybody has to know. There is no single reliever therapy at all, and there is an anti-inflammatory reliever. Now my question is, which part of the reliever is anti-inflammatory? Now I would like to ask the house and know from you, is ICS anti-inflammatory? Everybody says yes. Is LABA also anti-inflammatory? It is. Please remember, it is not just the reliever, not the SABA, but LABA also has some anti-inflammatory properties. That's why there is a synergism between LABA and ICS. I will ask the other way question, like, is steroids anti-inflammatory?
Yes.
Answer is yes. Is steroid a reliever? Answer is yes. Please remember. So therefore, we have discovered 2 new pharmacological functions. Steroid is also a reliever, and a LABA is also anti-inflammatory. Please remember this point. And that makes the science perfect. Therefore, we are combining them. It makes sense because instead of using a single reliever, now I am using two relievers, formoterol and ICS. And instead of using single controller, I am using two controllers, that is ICS and LABA. What I meant further is that the dependence on increasing doses of either of the drug is reduced by the combination, because the other drug in the combination has some extra or additional properties which can give a pharmacological advantage. Did I make sense of what is MART therapy? It was initially called SMART therapy. Now the Gina has made it only MART, not SMART, because S was referring to a pharma bias. And therefore they have taken out SMART and they have made it MART. This is another glossary or terminology, but don't worry, that is for pulmonology people, not for you. Now the second part which is very important is we were using the term called comorbid conditions. Do you all remember? And we still use the condition comorbid. But if you refer to Gina 2023 and if you read the adult part of it, there is a new terminology called as multi-morbid conditions. And that's a nice word and I liked it because there is nothing like elder brother or an younger sister for these comorbidities. Any one of them can be any of the Pancha Pandavas. It is not that asthma is Dharmaraja and rest of it is, the younger brothers would listen to asthma, like allergic rhinitis, obesity. And it's not that either of them in anywhere in the dynamics of life is going to be predominant. Let's say I will start the treatment of a moderately severe asthma with a severe obesity. And after 2 years, the child is now having a mild obesity with worse asthma. Or let's say the child continue to have obesity with mild asthma. Are you getting my point? So therefore, which is the comorbid of the which becomes a big question in the long-term management. And therefore, the word multi-morbid is used. Are you all clear, Vikram? Are you all comfortable to use the word multi-morbid instead of comorbid? And it makes sense that each one has to be managed. Now, there is not only synergy in the drugs, there is also synergy in these multi-morbid conditions. That means to say each one of them is an evil, but together they are worse evils than any one of them either alone. So these are the two concepts which I wanted to drive home and a changing scenario. Now, therefore, having understood the anti-reliever action of ICS and anti-inflammatory properties of LABA, can I use them in all patients with asthma? There is absolutely no problem from newborn to use up to 100 years of life off label. The only problem was lack of evidence of safety of LABA in children below 4 years of age and lack of number of studies for children between 6 to 11 years of age. In 2023, there were only 3 studies to support this. And subsequently, there is an emerging studies and there are ongoing studies. As the evidence evolve, maybe in 2024, there will be no difference between, I'm anticipating, maybe in a couple of months it will come. There will be no difference between 6 to 12 years and 12 years and above. It will all get merged. And about 12 years, I will have LAMA probably being imported. That's what is the change I'm anticipating. I'm giving you the future predictions, 2024 also. This is what is likely to come in the pipeline. Now, why do we need step up or step down? Step down is required to minimize the steroids. I agree. Now, the problem of track 1 and track 2. Let me tell you, if you use a combination MART therapy, the advantage is the patient has only single canister and he will use this as both anti-inflammatory as well as reliever. It's called AIR now, controller and reliever. So he will use it now. But whenever there is a flare up, he adds 1 puff, 2 puff. As Dr. Vikram was telling, you can go up to 72 micrograms. That is around 6 to 12 puffs based on the age. That's fair enough. Now the question is, in whom you are going to use these additional puffs? Can I go outside the Gina with permission of Dr. Chitra? Because I see in my practice two kinds of patients, and Dr. Vikram in the beginning told personalized medication. What we mean by personalized medication? In those patients who come with acute flare-up, there are two types of patients. Those of them, all of you agree with me, those of them who get mild worsenings of asthma, sufficient enough not to call them flare-ups, but they become somewhat symptomatic for a while and they become better. They are underreporting. They don't rush to your ICU, but they come to your OPDs only and telling that they're not better controlled, but they appear to be in flare-ups. Are you seeing this confusing pattern in practice? All of you,
Always.
do you agree on
Always.
this point? You have
Yes.
started on formoterol plus budesonide 100 microgram per day. He is not justifying to go for 200 of ICS, but has some kind of worsenings in between. In between, there is confusing also that 1 or 2 doses he skips. This is the problem. Are you getting the point?
Yes,
These
sir.
kinds of patients, I will use MART therapy, track 1, to tell him that if you have forgotten in the night, you add a puff. You can add additional 2 puffs and go on titrating and get reviewed by the pediatricians to adjust the dose of steroids to appropriate step. Am I clear? Now, I have got a second category of the patients who, irrespective of whatever you do, they frequently end up in ICUs. They do listen to you. Patients beg for treatment, but that's a brittle asthma where I will have problem. I have faced couple of patients like that, and in them I prescribed MART therapy. But they give additional 4 or 5 puffs at home and then come to your ICU. What you will give then? Can you give SABA after LABA? Are you getting my difficulty? Are you understanding my patient? You can't give SABA after LABA because LABA they saturate all the beta 2 of the airways. Additional SABAs may not work at that time. Although you have given, I don't know, Vikram, are you getting the scenario?
Yeah,
So
yes.
in these patients, I would prefer to keep ICS plus SABA separate and give sufficient doses of ICS, not cover up the symptoms with LABA. I will use track 2 in these patients, but agree on the point, you can go on track 1 to start with, which I mean to say I'll give formoterol plus ICS, but don't hesitate to give them SABA in addition. I will not ask them for second puff of ICS plus formoterol, but I'll ask them to take SABA and report to me so that I can increase the doses of steroids, not steroids plus LABA. Did I confuse all of you? I hope no. Chitra, did I confuse you?
Sir, to me, what I understood that in brittle asthma, we have to increase steroids separately
Yeah.
and not to increase the formoterol as
The
like in
reason
MART.
is, the reason is, if I ask you this question, what prevents deaths from asthma? I will come to separation of morbidity and mortality from asthma. If you look at asthma as a disease of morbidity, then MART therapy is excellent. If you think asthma as a disease of mortality, then you can't take away SABA and oxygen, and you need a steroid before you are fatigued with SABA and oxygen. Maybe a systemic steroid, not just an ICS additional puffs. Am I coming to that point? Are you all understanding, I suppose? And therefore, in such of those patients where mortality is at risk, you please give sufficient doses of steroids. But I don't mind for steroid sparing if you use ICS plus LABA. Should use ICS plus LABA for steroid sparing advantage, not for reliever advantage. Am I clear? You don't use that for reliever advantage. I don't say use only budesonide and salbutamol in those patients. Please use the combination. But tell them that in the night times, they should not keep on puffing the LABA plus ICS combination and arrive ICU very late so that nothing much could be done. I can't give them max help and manage. It is our ventilator patient, which is very, very difficult. And this forms less than 1% of the severe flare-ups. So do not worry about them. In large, the message is you can be comfortable in track 1 because till date, morbidity is more common than mortality in asthma. But there is a small difference between East and the West, India versus Western countries. In our countries, mortality is still high with asthma compared to the West, in the blacks. Whereas in the whites, morbidity is more than mortality with asthma. That means our patients in India present late, they are brittle, they are difficult to control, and prevention of death is more important than control of asthma given as priority. And therefore, be little careful in some selected patients about using track 1 alone and not prescribing SABA along with them. But when you prescribe SABA, you should be very, very careful, take them into confidence and educate and see that they don't go on with SABA alone and not use LABA plus SABA. This LABA plus ICS. This was the second message that I wanted to give. Now, I think the practitioners confuse between mild, moderate, and severe asthma severity in long term versus acute flare up. Mild asthma means mild asthma can have a severe flare up. Severe asthma can have a mild flare up. Am I clear to all of you? And it is the assessment over a period of time that decides somebody has mild, moderate, severe. Assessment at the point of time will decide whether a given flare up is mild, moderate, or severe. These two should not be confused, and please don't write them. So avoid writing mild, moderate, and severe asthma. You please write controlled, uncontrolled, or partially controlled asthma with mild, moderate, or severe flare up. This is my suggestion, because if you write mild asthma on ICS, I don't know whether you are referring to mild overall asthma or mild flare up of asthma. So therefore, let's use the term controlled, partially controlled, and uncontrolled for long term, and mild, moderate, and severe for flare ups only. Although mild, moderate, and severe can also be used for long term control of asthma. Am I clear? So I'm coming to glossaries and terminologies. Now, lastly, let me tell you, there was a question, and this is the answer. How long the ICS should be given as an add-on to SABA in below 5 years of age? There are two traits of patients in under 5 wheezing. I will tell you, recurrent wheezers, infrequent wheezers, who have risk factors for asthma, and those who don't have risk factors for asthma. What I meant by, I'll give child A, I'll say child Vikram, whose parents are fine. He is born 2.4 kilo weight. He was in NICU. He gets a bronchiolitis at 2 months of age. Again, he gets a bronchiolitis at 6 months of age because he was 2.4 kg and his airways caliber is not improved. And he gets the third bronchiolitis at 8 months of age. It appears like definition of asthma, but it is not asthma. Intrinsically, his airways are narrow and therefore he frequently wheezes. By definition, it is a recurrent wheezer. He responds to bronchodilator, then he doesn't require an anti-inflammatory medication. Am I clear? Versus Chaitra, who is 2.5 kg, gains rapid weight in infancy, become obese at the age of 4 years, continue to wheeze and wheeze frequently 3 or 4 times a year. Now she is tried to, who has inflammation in the airways, and the airways wheeze in attacks not because of intrinsic narrowing of the airways, but because of inflammation. This is a child which requires ICS in addition to SABA, whereas Vikram can be managed with SABA alone. Now, am I giving a message to everyone that recurrent bronchiolitis, in the second attack, you should give 2 weeks of ICS for all the patients? Answer is no. So for Vikram trait 1, you need not have to give ICS for 2 weeks. Whereas for Chaitra trait 2, You should give ICS coverage whenever you use SABA. Did I make that concept clear to all of you? So under 5 wheezing is a heterogeneous type. Still, you should identify inflammatory phenotypes and give them ICS coverage whenever SABA is used. And in non-inflammatory phenotypes, where there are no risk factors, you can manage with SABA alone, either as syrup or as tablet or as nebulization or as an MDI with or without mask. So this is the summary of treatment of under 5Es without confusion. If Maha IAP permits, again we will have controversies and going on with discussion under 5 easing. I will tell you I can speak for hours, but I don't want to go on and on that. The most confusing for all of you is level 1. Level 1, because in the level 1 it is mentioned viral infections, infrequent symptoms, and coming under definition of recurrent V's, what to do. Should you give ICS every time you use SABA? There is no clarity there. You can give ICS for 2 weeks whenever you give SABA, provided the reason for recurrent V's is a risk factor for asthma. If the reason for recurrence is not a risk factor for asthma, you have no business. Let me take the example of a missed foreign body with recurrent V's. Why you should give ICS of 2 weeks every time? So it makes sense when I'm telling you, when you have atypical visas or differential diagnosis, etc., or a strong evidence of a low birth weight and all that, you need not have to give ICS. But in those types, you feel those happy visas who are going to be probably having horoscope of asthma with them and a risk factor, you can consider giving ICS along with the SABA. I think that unclear part of under 5 controversial part I have touched with some remarks from me. But for all of you, when you have confusion in Gina 2023, I request all of you not to read the pediatric Gina. All of you open up the Gina pages and start reading from pediatric page. Please read the adult page. Then only will understand asthma. And because the pediatric chapter starts from some other page and it is chapter 8 or 9, when you have not read first 7 chapters, you will never understand what is written in the 8th chapter. This is the mistake most of us do, but a lot of us don't have time to read. So somewhere I think I request Maha IAP not to discuss pediatric asthma once in a while. Please discuss adult management of asthma once, because then they will get the clarity. Do you remember, if I just last line, let me tell you, the answer to pediatric tuberculosis, is it there in the childhood tuberculosis or is it there in the adult tuberculosis? The answer is there in adult tuberculosis. We are following the adult pattern of investigations, evaluations, sputum, everything, and extrapolating in childhood, even though it is difficult for us. All of us understand this point? Are you getting the point? Sputum examination was not our cup of tea in the past. We were only seeing lymph nodes and starting ATT. We were doing FNAC and getting some caseation and we were starting ATT. We have gone away from that. We are following the adult prototype. Similarly, in asthma, we are following the adult prototype and extrapolating it for the children. And we are gone up to 12 years. We are coming up to 6 years. We may go under 5 also. So therefore, I request all of you to read the adult GINA guidelines as well, in addition to pediatric GINA guidelines. Or whenever you have doubt, go back to the adult pages. Don't read the pediatric page second time. You will not understand. These are my simple lines for all of you. I hope that I was little clear. And if there are any questions also, we are happy to take up. I will mute myself.
Thank you so much, sir, for that elaborative explanation about Gina. May I hand over the screen to Dr. Jay Bhandarkar? He was going to ask some questions. My first question is that, sir, how to identify those at risk asthma between 6 to 11 years, which you have told that they always land up in ICUs?
Okay. Those of them who land up in ICU are at risk are those who have got the so-called description of near fatal asthma. That means to say, somebody gets into IR, takes a nebulization and walks away after half an hour, is not, and suppose he comes again to another time in ER, takes a nebulization, go away. This is not the prototype I'm talking. I'm talking of a person, you know that if he comes to ER, will go to ward, and from ward, you know that he is going to go to the ICU. Are you getting my point? So it is those kinds of categories who are definitely getting into ICU admissions, not the asthmas which are presenting to ER or emergency department with flare-ups. This is one. When there is deaths from asthma, they have done the histopathology of the airways and they have found that their airway characteristics are different from that of the normal airways. And that's why they are brittle to control. So that means there could be some structural problems in addition to inflammatory problems in them to make them poorly controlled or difficult to control when there are flare-ups. These are my explanations. More of this I will share with Jai, the articles. Please read those articles that refer to deaths in asthma. Then you will know, they will understand what I am trying to talk. We should first prevent the death, then control. But is death a common scenario in asthma? Answer is no. Death is common in infections, but not in asthma. Chitra, you are not, you are muted. You are muted, Chitra. Yeah.
Dr. Neha, any other questions? Have you noticed?
I will also see if there are any.
No, ma'am, I cannot see any questions. If anyone wants to unmute and ask any questions, they can.
But I will tell you only two lines. Let me not confuse the people. Don't worry about the rare cases or difficult cases that come in your practice. Use MART therapy in all patients. You are most often correct. Number two, you can use MART therapy. Hope that we are not getting recorded. Even in under 5 also, it is off-label use. Like we have used ciprofloxacin in newborns, when it was told initially that we should not use. Now we are using even tetracyclines in the form of doxycyclines, isn't it? We had a fear of using these drugs in the younger age. Only problem for Gina is recommending them without any evidence. But can you have an infusion to give? Answer is yes. You can use in 3 years. I have used. You have no problem, but provided you are sure of asthma. If you are not sure of asthma, please don't use ICS plus LABA.
Yes, sir. In practice, mainly the compliance matters.
So therefore, if you feel that somebody, you are sure of an inflammatory trait, father, mother have asthma, you can fairly use even in 3.5-year-old ICS plus LABA. Don't go by date of birth alone. Go by the nature of the disease. It's very important. And nature of the disease, you know that if you don't give today ICS plus LABA, in a year he comes to ICS plus LABA. You will come to know those types and you can start them very early.
Yeah, over to Dr. Vikram.
Nicely explains all the minute points, the confusing points about Gina. And sir, as mentioned, off level, definitely many cases are there who are on budesonide and as needed SABA. Still, they don't get relief. And once we start on MART therapy in below 5 years also, they show good response.
The biggest problem in under 5 evidences, let me tell you, right now, 2 of my postgraduate students are taking the study. Is nebulizer better or MDI better? We recommend MDI, but how many studies are there? There are hardly any studies. We recommend. Are you getting my point? There is a difference between strength of recommendation and number of studies available. So these are two different points. Number two, I'm also taking a study of levosalbutamol versus salbutamol in our setup. And I will tell you the results maybe in a year from now. We are also taking study on the device drug, and we are also studying on effectiveness of hypertonic saline in moderately severe bronchiolitis to be used or not to be used. I think these three gray areas we are taking the studies. Maybe I would love to share first on Maha-IAP screen only the results. And let me tell you that I will not allow the postgraduates to cook up a data however they want to do. Don't worry, I'll keep a track of everything on CCTV. So we'll get back to you with the data and proper data. Our own data should be there. The problem is that I would request Maha-IAP to call all the colleges, and one thesis done in one place should also be done in another place. Mumbai, Nagpur, and let's say Pune, three colleges can have same thesis so that it becomes a multicentric trial, although it is not a multicentric trial. This effort can be done from the IAP organization so that different colleges get integrated for studies, and any one of the colleges right now, if they are ready to take up these topics, I will share the study type and you can do the similar study. We can combine the results to get a better yield.
Yes, sir. And the studies which will be there will be having much more data as compared to West. Here I could see Dr. Sanap. He has put on his video on. Do you want to ask something? Please ask. Please unmute and ask. No other new questions? So shall we call up for the day?
Ma'am,
Can I make
one
a
question.
request, Chaitra, with
Yes.
your permission?
Yes,
One
sir.
question.
No,
Yeah,
this
there is one question, sir.
a question, please.
Yeah. Please go ahead.
Can we use probiotics such as Respistrong for decreasing the duration of therapy or repeated attacks and failure of treatment?
You are referring to asthma?
Yes, sir.
Okay. Now there are beautiful articles on gut-lung axis, and I think Vikram, being an allergist, is smiling. He will answer better than me because he's an allergist, but I'm only a pulmonologist. So the summary is that the microbiota of the gut will influence that of the lungs. Please understand the gut and the lung are evolved from the same embryological origin. From the foregut, the respiratory tract is an extension, and they share similar epithelium. They share similar subepithelial lymphoid tissues which behave similarly. So if there is eosinophilia in the gut, there will be eosinophilia in the lungs. And if there is an altered dysbiosis in the intestine, there will be dysmicrobiota flora in the respiratory tract. Majority of these are under research. Please read articles on biofilm, read articles on gut-lung axis. The time doesn't permit me, but let me tell you, it starts from the gut. That's why prevention of asthma starts with breastfeeding. And I'm very happy today breastfeeding was addressed in the first session. That's why I'm feeling very proud. But the point, can see smile on the face of Dr. Mohanty. No, that's how it is. The prevention of asthma not starts in the respiratory, it starts in the gut. And that's important for us. Sensitization first happens in the gut, followed by flare-ups happen in the lungs. So it's always that we don't inhale first, but we ingest first. So that's important for us, and it takes a long time for the airway inflammation. Now the question for the person who has asked this is, do you think asthma is a disease of airways, or you think it is a disease of the child where airways are involved? If you think it is a disease of airways, then you don't worry about the gut. If you think asthma is a disease of the child where airways are involved, then I think gut microbiota matters. How can I differentiate between these two types? If you have only respiratory symptoms, then probably it is an asthma involving only the airways. If you have multi-system features like atopy, you have intolerances, you have type 1 hypersensitivity, you have also asthma and flare-ups, That means you are referring to a child with allergy. That's it. That's a candidate for skin prick test, not just controllers alone. Whereas a child which has no systemic symptoms of atopy or allergy, but has only intrinsic respiratory disease, that is when I'm not bothered about the gut. That child would just require controller therapy and appropriate LABA in addition.
Thank you, sir. Thank you. Thank you.
I would like to extend a few points in this part. When we are coming for the probiotics in allergy,
Sir,
Now-
sir, your mic. Please increase the volume.
Just come closer.
so when we are talking about probiotics in allergy practice, now as sir mentioned, airway is a part of allergy. Now we have to understand atopic march, where an infant at around 2 or 3 months of age presents with atopic dermatitis, and when complementary feeding is started at around 6 months to 12 months of age, they present with food allergies. So the studies basically with the probiotics were to prevent food allergies after atopic dermatitis. So there is still no organization except for the World Allergy Organization, which has got the low evidence level to support the use of probiotics in allergy and in halting the atopic march. No other guidelines or no other organization supports this theory. And the molecule what you talked, and in asthma, there is no, because already there is an established TH2 what do you say dominance, so there will be no use, and the studies are going on still inconclusive. You are getting both ways the results, so no definite guideline.
Yeah.
And the molecule
Vikram.
what you talked about, Respistrong, that the company even is promoting for the recurrent infection, not for the asthma. And for allergy, what probiotic has been recommended by World Allergy Organization is Rhamnosus GG only. Yes, sir.
I
You were
think
saying
before the
something, yeah.
probioticology confuses us, we should have clarity. There are different types of probiotics.
Yes.
That is going to be after Lok Sabha elections. There can be more alliances for probiotics that are going to come up. So therefore, we should be very careful, because many of the types, what I see, the literature is pharma driven, hype from the pharma, low quality evidences, high quality speakers speaking on them. Please be careful about all the prebiotic speakers about probiotics.
Yes, sir.
Sir, Nimen Mohanty, sir.
Mohanty sir is here. He is master in probiotics. So your comment, sir, about probiotics.
No, I repeatedly said it's industry driven. Industry driven, except the viral diarrhea or Saccharomyces boulardii or Lactobacillus GG, there is no role for any probiotic. And now they are pleading Lactobacillus reuteri for anything and everything. So this is a new trend they are coming up with, even infant alcoholics, starting from infant alcoholic to behavioral therapy.
Mohanty sir, on a lighter vein, I want to just ask, is there a probiotic for baldness? That answers, I think, all the queries. And it is going to come, I'll tell you. There will be one bacilli that increases the growth of hair in all baldis. That's how the pharma works.
Very bad.
Now, let me, with permission of Chitra, wants to tell the forum, whosoever is attending, that we are starting respiratory tract infection course. I'm not doing any promotion of that, but I'm telling you, a lot of pediatricians met me and told me we want to have clarity on management of respiratory tract infections in day-to-day practice as well as in the wards. There is a lot of heterogeneity of practice in India, and therefore we are starting the course. I'll share the link. For those of you who want the link, please message to me and you can join and learn for 3 months online and take an online exam and get updated. It is not, don't worry about certificates. I think if you manage your day-to-day respiratory tract infections properly, scientifically, and in a simple way, I think it goes a long way in the management, because still I see questions coming on various diseases on my WhatsApp. So all those WhatsApp friends of mine, I have pulled them into a course so that they don't ask any questions thereafter. So please understand, and this is not into promotional mind, but I'm telling you in this sense. There is also free entry to that course also. We have there is a paid entry also. The free entry is only for some invited guest lectures. course is for those who are serious about learning. You have to read, attend the exams, and therefore there is a pattern to it. So we would welcome all of you. May I also request any one of you wants to be the faculties, you are also welcome, not necessarily participants. So thank you very much. And there was a lovely discussion on the first topic, breastfeeding. And you know, it was fantastic for me to listen to you. I'm complimenting you, Mohanty sir. There are very few advocates of breastfeeding, long live breastfeeding, even before asthma, because if breastfeeding is there won't be good candidates for asthma. That's what is protecting us. And thank you very much.
Thank you, sir. Thank you so much. So kind of you.
Thank you. I could see Raigad IIP President Dr. Vikas More. Sir, do you want to ask some questions or shall we wind up?
It is completely self-explanatory and it is a treat to hear Subramaniam sir. And on the top of Vikram is there. So it was a fantastic session. Everybody has enjoyed it thoroughly. Thank you so much.
Yeah, sir, will you do the honors to thank all the experts as well as presenters?
Sure, madam.
Thank you.
So,
Yes, start.
yes. Ma'am. So, at the outset, on the behalf of IB Raigad and MahaIP, I am thankful to Subramaniam sir for being the expert and Swarup Kumar Das from UAE. Presenters, Dr. Mitali and Vikram has done justice to their presentation. And I am also thankful to Dr. Ram Gopal Chajera sir, Dr. Amul Pawar, because MahaIP is working hard to spread this journey to nooks and corners of Maharashtra. And at the end, our own respected Mohanty sir, Chitra madam, and Neha, everybody is working very well. And at last, all delegates, thank you so much for your active participation, even at 10:30 the night. Thank you so much.
Bye-bye. Thank you.
Thank
Bye-bye.
you, Dr. Vikas.
Thank you,
and
Chitra.
also
Thank you so much personally.
Yeah, thank you,
Chitra,
sir.
thank you so much personally.